demonstrating the inferior oblique recession, I have actually taken the suture and I have exposed the infero-temporal part of the conjunctiva and the fornix. So the inferior oblique, if we want to approach via the fornix route, I think nearly from the limbus, infero-temporally about 8 millimeter beyond, at about 8 millimeter, we would like to go and take a fornicial incision. You can remove. So this is an infero-temporal. I would like to extend my incision more towards inferior rectus because that is where we would be further doing the recession of the oblique part. This, if you can see here, you can see this bunch,
yes,
belly and slightly purplish hook. You need to always remember that the inferior oblique has to be hooked, can you mop it, under direct visualization, basically because inferior oblique is closely attached to lot of structures. For example, just hold this for me, hold it this way, pull this. So inferior oblique scissors, inferior oblique is very closely related to macula. Inferior oblique is very closely related to infero-temporal fat pad. Inferior oblique is again related to the optic nerve, also to some extent near the insertion site. So always visualize, take some time, no problem, do visualize the inferior oblique fully.
Very important.
Only then, yes, that's the most important point. So I am trying to look around as posterior as possible. And you can see this white area here. So this means that the muscle beyond this point, the muscle doesn't exist. So I go with another hook. No, I'll re-show that once again. So
what do you call this?
The white triangle.
White triangle, okay.
So the hooking.
Okay, very good, very nice,
so
very nice.
So if you can see this, now you can see the white area in the middle of the two parts.
Yes.
So this basically indicates that I have held the full belly. Okay, so remember that the inferior oblique can have, now can you give me the Green's hook? So the inferior oblique can have 2 to 3 origin. If we don't completely hold this Isha, if we don't completely hold the inferior oblique, then there is a chances of recurrence of inferior oblique overaction despite you performing the complete, yes. So now the next step, once you, so this is our inferior oblique muscle. So be very careful, but when you are dissecting, try to dissect on either side to some extent. I take 2 sutures, cut, yes, 60 sutures, so 1. I do that way, but whenever I teach my fellows, I always tell them take 2 full thickness sutures only for few days till you are completely sure कि तुम्हारा muscle slip नहीं हो जाएगा. That is very important. Be with muscles, always it is better to be careful than maybe later we thinking that we have lost the muscle. So I am taking 2 sutures on either side. There is another point in inferior oblique here that some people cut and then take sutures. Some people take suture and then cut the muscle. Doesn't matter because inferior oblique originates from your maxillary bone. So it cannot get lost in the orbit. It will be somewhere dangling there only. So you can cut and take also. But I don't like crushing any muscle. As a strabismologist, we are always taught to respect the muscle. And I think so this, beyond the suture, I am cutting the inferior oblique muscle. So what do we mean by inferior oblique recession is, it was attached near the lateral rectus. Now we go and attach it. Now I hook the inferior rectus muscle. So this is inferior rectus. Yes, that never tackles single eye inferior oblique until and unless you are doing something like superior oblique palsy. Always tackle both eye inferior oblique together. You don't want the other eye inferior oblique to be masked later.
That much of recession will be happening. So this will be around 10 millimeter.
10 millimeter, exactly. So now
4 millimeter behind the insertion.
So basically recession means that we bring the muscle more towards its origin. So we are pushing, now we remember that the inferior oblique originates here from the maxillary bone. So now from near the lateral rectus we have removed it and we are bringing it near the inferior rectus. So we are making it more weaker, and that is how that is causing the recession effect. The more and more it goes closer to inferior rectus, it becomes more and more weaker. In this case, I have put it nearly 3 millimeter away. That is as good as bunching up, sir. But bunching up is the best to prevent the anti-elevation syndrome. So here I have just taken about 2 to 3 millimeter away. But important.
for
I took one
surgeon.
extra bite. In fact, I didn't want
Yeah.
it to hang
we
and
don't,
loose. The inferior oblique, which was near the lateral rectus, has now come and sat near the inferior rectus. So that is the inferior oblique recession. So we can, there is another type, the other eye I would be doing a modified Elliott and Nankin, where I'll just put it and bring it beside the inferior rectus per se. So myectomy and Z myotomy.
Yes.
This is graded recession, sir.
Beautiful.
I think
Very
it
nice.
Very beautiful.
Here I did a modified Elliott and Nankin, so I just put this inferior oblique about 1 millimeter behind the IR. So I was just wrapping it up. This is the thing, inferior oblique attached. Otherwise, this side didn't have any other muscle to be done. The other eye I had performed a lateral rectus recession as well as medial rectus plication along with
All
it.
that you have
So,
done. That was a real fantastic demonstration. Thank you very much for coming all the way from Hubli.
Thank you, sir.
I think we should give a big round of applause for Dr. Deepti,
Thank you,
Anisha, and the entire team here.